So my name is Joseph Dottino. I'm one of the G1 oncologists here at Beth Israel Hospital. Today, I've been here for about a year so far. And it's been wonderful to work at this great institution with wonderful colleagues and get to know everybody since I've been here. So today I'll be talking about hereditary ovarian cancer. The title is BRCA and Beyond, and I really hope we didn't oversell this because the beyond is very finite. I'm really envisioning that this is going to be not just a webinar, but more of a webin discussion. So I hope if anybody has questions that they'll chime in. Kelsey, I don't know is there a way to can they ask through the chat or talk, or how does that work if there's a question from the audience? Do we reserve it at the end, or what happens?
So it's up to you. There's the little Q&A chat where people can ask questions at the bottom. And then it's up to you if you want to sort of answer them as you go, or you can wait until the end.
Okay, I'm all for pausing and talking. So if anybody has any questions, we could I'll make sure we check the chat box. Okay. So I have no financial disclosures as of yet. So just to give an overview of what we'll be talking about today, and I'm planning to talk for maybe around 35-40 minutes or so to leave some time for questions, but we're going to give a little bit of background about ovarian cancer, hereditary ovarian cancer, who we test and why we test, and a little bit about how we test, specifically thinking about affected and unaffected individuals and how that differs and what our goals are and how they differ. Thinking about risk reduction for known BRCA carriers, what our strategies are, and what are some considerations around those strategies. And take a few minutes to think about some of the some controversies around that as well. What I won't be discussing tonight will be any non-epithelial hereditary ovarian cancer syndromes, so some of the more rare hereditary cancer syndromes. I'm happy to do that at another time, or if somebody has more specific questions, they could always shoot me an email and we could talk offline. So I for not a small amount of time, I considered, before I went into medicine, thinking about instead going into cartooning full time, but the pay is not so great and the benefits are terrible. But I still try to cartoon as much as I can, and this was one I had done that is a little relevant to our topic tonight. And so this is for those of you who are only listening to the audio version of this, there's a nervous looking young boy asking his mom, what if anxiety is hereditary? If only we had a test for that. This was rejected from just about every major publication you could imagine. Okay, so just to give some background, just thinking about ovarian cancer generally, there's an estimated 21,000 new cases in the US, there was an estimated 21,000 new cases in the US in 2021, and almost 14,000 deaths. That 5-year survival rate for the year 2021, or looking at that preceding few years time period, approached about 50%, which is an improvement when you look historically back in this disease. Ovarian cancer is the second most common gynecologic malignancy that we treat after endometrial cancer or uterine cancer. But it is the most common cause of gynecologic death. And this is because we still tend to diagnose this disease at a more advanced stage. We don't have routine screening for ovarian cancer. And it is generally an aggressive cancer. The majority of these cancers are derived from epithelial cells, the remainder from the other ovarian cell types, such as germ cells and sex-core stromal cells. And the most common are high-grade serous epithelial ovarian cancers. And for the purposes of this talk, because they're treated the same and they're grouped together in the literature, when I refer to a high-grade serous epithelial ovarian cancer, I'll be lumping in fallopian tube and primary peritoneal carcinomas as well. Up to about 24% of ovarian cancer cases can be due to an underlying inherited predisposition. And germline mutations in the BRCA1 or BRCA2 genes account for the majority of these hereditary cancers. So about 15 to 20% of high-grade serous ovarian cancers are going to be related to a mutation in germline mutation in one or two of those genes. Hereditary breast and ovarian cancer syndrome is really when we talk about this syndrome, we're describing the germline mutations in the BRCA1 or 2 genes. They're the most commonly mutated genes in the BRCA Fanconi anemia DNA repair pathway, which regulates DNA repair via this process of homologous recombination. And now there are other genes in that pathway that can be mutated and inherited, which include RAD51C, D, and BRIP1 is listed there below, which can also confer a risk of ovarian cancer for patients who inherit those mutations. But BRCA1 and 2 is by far the most common. Germline mutations in BRCA1 and 2 are inherited in an autosomal dominant fashion. And so that classic mechanism of having an inherited mutation and then a second hit somatic mutation in the normal allele leads to a loss of function. And then this HRD, or the homologous repair deficiency, this error in DNA repair that causes the predisposition for developing these cancers. While the prevalence is low in an unselected US population, it's around 1 in 300 to 1 in 800 individuals. This is higher in certain ethnic populations, such as Ashkenazi Jewish women, French Canadian, and women of Icelandic backgrounds. Germline mutations in BRCA1 and 2 carriers also have as the name of the syndrome suggests, have an increased lifetime risk of developing breast cancers as well. And it's a highly prevalent, penetrant syndrome. So for BRCA1 carriers, there's about a 40% lifetime risk of developing an ovarian cancer, and about half of that, a 20% lifetime risk within BRCA2 carriers. One important distinction that'll be brought up again later in the talk is that risk of developing an ovarian cancer with BRCA2 mutations tends to be later, about 10 years later in onset compared to BRCA1. The breast cancer risk in both BRCA1 and 2 does exceed 60% for the lifetime risk. And then there are several other cancers that are associated with this syndrome, including pancreatic, prostate, and melanomas as well. A good way of kind of framing this talk, I thought, would be to include 1 or 2 cases, and so we can go through that briefly and use that as a way of discussing some of these topics. So in this first case here, we have a 58-year-old woman who presents with abdominal pain and bloating. Her CT scan shows a pelvic mass and omental caking, ascites, and an elevated CA125, which is our tumor marker that we'll regularly use to help inform our diagnosis when we're thinking about ovarian cancer. And that will come up again when we start talking about screening. For this patient, her family history is negative. For relatives that have a history of breast or ovarian cancers, and she undergoes a surgery where we remove the ovary and then do a debulking, and the final pathology was consistent with a high-grade serous ovarian cancer. The first question we could ask here is, does this patient need genetic testing? We already know that she has a ovarian cancer, and so do we need to know that this was due to an inherited mutation? The question of who we test, I tend to think of it in 2 big categories. This slide is a little bit of a joke here. I know it's very, very busy. And when I see the guidelines for who we should be thinking about testing for hereditary cancer syndromes, it can be very overwhelming to think about, does this patient fit this criteria, or do they have this degree relative with this cancer? The way I tend to think about it and break it down is, and it's easier in my practice, is really, is this patient affected or unaffected, right? And it's far simpler for patients who are affected. So and this is true if they have breast cancer too, because you can see you can start to narrow down your criteria. But if a patient has a known diagnosis of epithelial ovarian cancer, really not non-mucinous epithelial ovarian cancer, and then again that includes the aforementioned fallopian tube primary peritoneal cancer at any age, it doesn't matter what age, they should undergo a genetic risk assessment. They should undergo genetic testing. When we and that should include the bare minimum BRCA germline testing. When more than one gene can explain an inherited cancer syndrome, generally multi-gene testing is recommended. So in addition to thinking about BRCA1 and 2 testing, you also have to think about those other genes that are involved in the in that DNA repair pathway that I had mentioned. So that includes BRIP1, RAD51C, RAD51D, PALB2, and with referral to genetic counseling, the patient your patient will usually be recommended to undergo some kind of panel testing, depending on where you are, or what the resources may be available within your own institution. Again, at the bare minimum, we should be thinking about BRCA1 and 2 testing for these patients who have a known diagnosis of epithelial ovarian cancer. One, because this is the most common mutations that we will see, and then two, specifically with those genes, there are some other therapeutic implications. The next slide here. The rationale for genetic testing does differ a little bit between those who are affected and unaffected. So again, in our case, that case where we have a patient with a known diagnosis of ovarian cancer, knowing the mutational status in those patients can inform not just our knowledge of tumor biology, but also prognosis, inform treatment decisions and treatment options, as well as the potential for clinical trial enrollment. If we know that the patient has a known hereditary mutation, they may be eligible to participate in certain clinical trials that would otherwise, they would not be available to enter. And then, of course, and this is true for both the affected and unaffected, but this also provides a risk assessment and prevention of subsequent malignancies. And so in the case of BRCA1 and 2, where we know that there is a risk of developing a breast cancer as well, it gives us the opportunity to employ screening specific to breast cancer for those patients with BRCA1 and 2. For the unaffected individual, for somebody who does not have a known cancer already, the rationale for genetic testing is obviously to help mitigate the risk of developing a cancer for that patient and for their relatives through cascade testing. So testing other individuals. And specifically here, it may be that the unaffected individual that you meet has a relative that has a known diagnosis of ovarian cancer. They're not sure what that mutation is. It may be that they come to you with a specific mutation in hand. But this gives us the chance to potentially offer them strategies to help reduce the risk of developing a cancer in the future. So for our patient who has a known ovarian cancer and also a germline BRCA1 and 2 mutation, is the treatment different for those patients? Now, currently, for patients with a new diagnosis of ovarian cancer, the upfront management, and by that I mean the surgical strategies that we employ and the chemotherapy that we use, which is platinum-based doublet, usually carboplatin and Taxol, is going to be the same for those patients who have or do not have BRCA mutations. We do know that those patients do have different prognoses. There's an improved survival that is associated with BRCA1 and 2, so it confers a favorable prognosis. And there is a increased sensitivity to platinum-based chemotherapy for those patients who have a BRCA1 or 2 mutation. And that is because those patients who have BRCA mutated tumors with their impaired DNA repair process due to their homologous recombination deficiency are uniquely susceptible to targeted therapies that we can offer that exploit those vulnerabilities, such as PARP inhibitor therapy. And that same reason why PARP inhibitor therapy is going to work, and let's talk about it in the next slide, is the same reason why chemotherapy is also more sensitive to these patients, because their DNA repair is impaired. PARP inhibitors have really changed the landscape of ovarian cancer treatment. And this is something that's really, over the last 7-8 years has really completely changed the way that we treat patients with ovarian cancer. It's completely changed the drugs that they receive. It's affecting the amount of chemotherapy that they're on, the time that they're on chemotherapy, and the likelihood of cure in some cases, as we're learning with more data. So PARP inhibitor therapy is an oral treatment. It's a pill that patients can take. It was first approved in the ovarian cancer space in 2014. But since that time, it's been approved. There's been multiple PARP inhibitors that have been approved. So 3 currently in the United States with multiple indications, both as treatment for ovarian cancer in the recurrent disease space, and as a maintenance drug for ovarian cancer, meaning that after the patient has completed their course of chemotherapy, they can go on PARP inhibitors, this oral therapy, to help reduce the risk of this coming back. And it's been shown for certain patients, especially those who have BRCA mutations, to have tremendous impact on their progression-free survival, and in some cases, as we're learning now most recently, overall survival if it's used earlier in the disease course. Here's a small, this cartoon describes where PARP inhibitors act in this DNA repair pathway, and why the rationale for why it's working. And this is just one mechanism of how PARP inhibitors work. There are some other mechanisms as well. But in the case where there's DNA damage, the PARP inhibitor does block that ability to repair, and such that patients who have impaired homologous recombination, which is in the case of BRCA tumors, they can't repair their DNA in the normal way. The cell will then go on to lead to cell death. And so the combination of using a PARP inhibitor to impair that normal DNA repair pathway, combined with the BRCA tumors inherent inability to repair that DNA, will lead to that combination of cells dying off, and so increased sensitivity to things like chemotherapy and response. The patients without germline BRCA mutations get a benefit from PARP therapy. So that because PARP therapy has really changed the kind of what we're able to do and how this cancer is treated. Are there other patients besides for those who have a known germline BRCA 1 or 2 mutation who could benefit from this drug? Tumors that are BRCA mutated can be due to either germline mutations, such as in the case of hereditary BRCA 1 and 2, right? So a germline mutation is one that is present in germ cells at conception and that are inherited throughout generations. Meaning that on testing, you can test, do saliva or blood testing to be able to determine if the patient has a mutation in a germline mutation in BRCA 1 or 2. But there can also be somatic mutations, sporadic mutations that occur within the cancer itself. So these are mutations that are perpetuated within a specific cell lineage, and they're not passed on to future generations. And so ovarian cancers can have BRCA mutations themselves, even if the patients do not carry a germline BRCA mutation. And for those patients who have a BRCA somatic mutated tumor, their cancers are similarly responsive to PARP inhibitor therapy. There's also a third category of patients who have this impaired ability to repair DNA, this homologous recombination deficiency, or HRD, without a known somatic BRCA mutation or a known germline BRCA mutation. And for those patients who are homologous recombination deficient, they also have a susceptibility and a PARP inhibitor efficacy in their cancers. And that can be tested for using companion diagnostics, testing the tumor itself as opposed to testing the blood or the saliva. PARP inhibitors, as I mentioned, have kind of exploded on the scene here since 2014. So this is a map from 2014 to about the present. And this is looking at all the different PARP inhibitors that have been approved in the US and in Europe. So green is Europe and blue is the United States. And I apologize if you can't see this very well. But as you can see, not only have there been multiple different types of PARP inhibitors, so the olaparib, rucaparib, and olaparib, but also for different patient populations. So some of these FDA approvals have been specific to patients who have germline BRCA mutations. Some of the approvals have been specific to patients who have somatic, may include patients who have somatic mutations in their tumors. And then other approvals will include patients who are HRD positive or who have homologous recombination deficiency proven tumors on testing. The other thing I'll point out here is as we've accrued approvals over the years, that the time when we are able to use this drug has also increased. So most recently, while initially we were using this in the treatment setting after 3 lines of chemotherapy, now we have the opportunity to use this in the upfront setting. So immediately after diagnosis, surgery, and then they finish chemotherapy, patients could be eligible to receive PARP inhibitors as a maintenance drug. And the different types of PARP inhibitors, again, even in that upfront space, there's a role for that for patients who have germline BRCA mutations and those who do not have germline BRCA mutations. And that leads to the question of who should get the PARP, who should get a PARP inhibitor and when. And I think, not to be too controversial, but I think we're probably at a place, or pretty soon to being at a place, where just about every patient who is diagnosed with ovarian cancer potentially could get a PARP inhibitor at some point in their cancer care. Whether that's the right thing or not is debatable, but it's probably, within the next few years, I would not be surprised if every patient who has a diagnosis of epithelial ovarian cancer would have seen this drug at some point. So the question of thinking about patients who are eligible to receive this drug, or the different indications for getting it, or knowing that there are certain patients who may have an advantage to receiving it, such as those with a germline BRCA mutation or a tumor mutation, the question of integrating genetic testing in general for these patients is a bit of a strategy endeavor here. So one approach would be to think about germline testing all patients at initial diagnosis. Again, we want to know what the hereditary status of BRCA is for patients with a new diagnosis of ovarian cancer. But if that's negative, there is then a role for thinking about, well, should we test the tumor for somatic mutations in BRCA? Should we test the tumor for homologous recombination deficiency? Because we know that for patients who have these homologous recombination deficiency or somatic mutations in BRCA, they are still going to benefit from receiving this drug in the same way that germline BRCA patients would. So the other PARP considerations would be then in this case is which PARP inhibitor to give, because of the 3 PARP inhibitors that we use now, they have different side effects, different adverse effects profile that may you may choose one or the other based on patients' known history of response to chemotherapy, or avoiding if they have other medical comorbidities that you have to manage. So, for example, they're managing hematologic toxicities if they were especially their bone marrow was especially suppressed with receiving chemotherapy. It may help you to choose one of the PARP inhibitors that may be less prone to anemia or thrombocytopenia. the other thing would be is knowing the patient's germline status. And so we know that for some indications, for some PARP inhibitors, that the FDA approval is contingent upon having a germline BRCA mutation. For example, in olaparib, in the upfront maintenance setting, that FDA approval is based on having a germline BRCA mutation. And so that's another way that'll help to make the decision of which PARP inhibitor to give. The next consideration would be is if a patient is taking a PARP inhibitor for maintenance therapy, when do we stop giving the drug? Because while the studies have looked at using this drug for up to 2 years, which is remarkable, to have several years out of being cancer free for such a cancer with a poor prognosis. When do we stop giving the drug, or how can we stop giving the drug when patients may be having a perceived benefit from it, which is not without controversy. The other thought is, what is the risk of secondary malignancy? Because while the literature quotes the risk of developing myelodysplastic syndrome or AML, leukemia, with the use of PARP inhibitor after receipt of platinum-based chemotherapy to be around 1 to 2%. As we use more of this drug, more PARP inhibitors, especially for patients who maybe receive more chemotherapy over their disease course, and the patients are living longer, it may be that we see that true risk of secondary malignancy may be better understood over time. Because again, these drugs have only been approved relatively recently in the last few years, and the pool of eligible patients to receive this drug is expanded dramatically over the last even 2 years. And then finally, thinking about the cost of these drugs, which are not inexpensive. And for those patients who may be underinsured or uninsured, making sure that they have access to these good medications if they are eligible to receive them. For our patient who had the high-grade serous ovarian cancer, she underwent germline testing and was found to have a BRCA2 mutation. So she went on to complete her 6 cycles of chemotherapy, as any patient would with a diagnosis of ovarian cancer. And then she started on a PARP inhibitor, the olaparib, for a maintenance therapy, which she would continue out for 2 years. She has a daughter that is 30 years old, who had previously taken a direct-to-consumer test, and this is these kind of take-home genetic swabs that you can take that describe your ancestry and so forth. And there are some that do offer BRCA mutation assessments. And she states that she's negative for a BRCA mutation based on this test. So she asks, should she still see genetic counseling? Yeah, obviously the answer is yes here, because to date, the direct-to-consumer genetic testing platforms that are available commercially now that patients can buy on Amazon, they are very limited in the types of BRCA mutations that they test for. They are not the most common that we see in the general population, while they may be in the most common that we see in certain ethnic populations. And while they may suggest an increased or a decreased risk of having this mutation, it can't prove this or eliminate it because of the limited scope of the test. And so clearly, this patient who has her mother has a BRCA2 mutation, she should go to genetic counseling and undergo formal genetic testing. But the same would be true in patients who present with this test and have a new diagnosis of ovarian cancer themselves. I would not rely on a direct-to-consumer genetic test as being a definitive way of saying whether somebody has a germline BRCA mutation or not. And so the patient's daughter goes to genetic counseling, and she ends up undergoing genetic testing. In this case, she wouldn't have to undergo this multi-gene panel testing because her mother has a known BRCA2 mutation, and so that specific mutation can be tested for. So she does test positive for that, and so then she asks, well, what risk-reducing strategies are available to me to help reduce my risk of developing an ovarian cancer? Of the kind of major societal guidelines that that have statements on ovarian cancer risk management. Excuse me. Generally speaking, they all concur that there's just not great evidence to support screening in this population. And by screening, I mean use of transvaginal ultrasound or CA-125 blood test to help screen patients, even these high-risk patients, for an ovarian cancer. Now, that being said, the NCCN, or the National Comprehensive Cancer Network guidelines do state that it's reasonable to consider doing testing in patients, especially for those who are close to the age where you would consider a risk-reducing surgery, as long as the patient is counseled on the limitations of this testing. The reason is it's just not great, and we don't have good data to support kind of the widespread use within this population. We would still end up missing cancers, and we would still end up overdiagnosing. Risk-reducing surgery in general is the single best strategy we have for preventing development of ovarian cancers in this high-risk population. Although I will point out before I move on to the next slide here that both ACOG and NCCN does recommend a discussion with the patient regarding oral contraceptive pills, which have been shown to reduce the risk of developing ovarian cancer by as much as 50–60% with longer use. I don't know if I would counsel patients in using that as a primary risk reduction strategy, depending on kind of where I met them in their timeline. But patients should be counseled, and this is not a contraindication to using the oral contraceptive pills with the risk of developing a breast cancer. But at the same time, it is certainly worth kind of discussing, all things being equal, if the patient is considering using a method of contraception, and providing that risk reduction in this case would be an extra benefit. In terms of risk-reducing surgery, when we talk about risk-reducing surgery in BRCA 1 and 2 patients, we're really talking about salpingo-oophorectomy, which is usually done laparoscopically. The general recommendations would be after completion of childbearing, generally between the ages of 35 and 40 for women with a BRCA1 mutation, and a little bit later, so between the ages of 40 and 45 for patients with a known BRCA2 mutation. And the reason we're able to delay that a bit in the BRCA2 mutation carriers is that the age of presentation and the risk of developing a BRCA associated cancer, ovarian cancer in BRCA2 mutations, is about 10 years later than that of BRCA1, as I mentioned earlier. And it's nearly closer, not quite, but it's nearly closer to the average age of diagnosis of the general population. One caveat would be is the age of diagnosis of a family member, first degree relative. So if the patient's mom had been 40 or 45 at the age of her diagnosis of BRCA2 related ovarian cancer, it is you should discuss with the patient a earlier risk-reducing surgery. This risk-reducing surgery does reduce the risk of ovarian cancer by greater than 80–85% in these carriers, and it also has a benefit in terms of reduction of all-cause mortality. The older age at the time of doing this surgery, so the longer that risk-reducing surgery is delayed, is associated with an increased risk of finding an occult cancer or diagnosing a cancer at the time of the risk-reducing surgery. So, for example, while the risk is low in BRCA1 carriers, less than 2% under the age of 40, that more than doubles over the age of 40, between the ages of 40 and 49. And obviously, as you wait longer and longer, if the patient were to find that out later in life, that risk only increases. Some other considerations would be kind of how we do this procedure and kind of why. So this is doing a salpingectomy or staging the risk-reducing surgery, doing a salpingectomy alone and waiting to do a nephrectomy. I found that a lot of patients have asked me about this recently, and I don't know whether there was something in the popular media, but it is an attractive potential alternative for two reasons. One, we know that we're going to be we likely are going to be preventing ovarian cancers, just given that the tubal origin of many of these tumors, by removing the tubes alone, and by removing the tubes alone and sparing the ovaries, we are delaying the iatrogenic early menopause that we're putting patients in by doing a risk-reducing surgery such as this. And for a patient who may be 35 or 40, that surgical menopause can be profound, and we'll talk about that in a second. Currently, doing a salpingectomy alone is not recommended as the current standard of care. We do have some good retrospective data that suggests its safety and efficacy, but really more data is needed, I think, before we're able to kind of fully endorse this as a strategy. There are some clinical trials ongoing looking at not just efficacy and safety, but also quality of life measures in this patient population. So, it's the hope that as these trials get published and that data is kind of discussed and integrated into guidelines, it may be that we have another option to offer these patients, perhaps doing a salpingectomy even at an earlier age immediately following childbearing. Or if the patient is considering doing something like in vitro fertilization even earlier, and then performing a nephrectomy at a later date, and perhaps just having more time without going through menopause. Another consideration is really adherence to surgical and pathologic protocols in risk-reducing surgery. Really decreases the risk of missing an occult malignancy. And so while bilateral salpingo oophorectomy is technically a fairly straightforward procedure, making sure that washings, putting fluid into the pelvis and then removing it to send it for cytology, doing pelvic washings is essential as part of the protocol to be able to look for occult cancer. Making sure that the reading pathologist knows that this is a patient who has a hereditary cancer syndrome, so that way the pathologic specimens are appropriately serially sectioned, looking for potentially for occult malignancy, microscopic disease, or precursor lesions within the fallopian tube. So having the right pathologic protocols to be able to process the specimens from these surgeries to make sure we're properly evaluating is also essential. After doing a risk-reducing salpingo oophorectomy, there is still a small persistent risk of developing a primary peritoneal cancer, and the within the literature, the rates for that are that kind of, it's a little wide there from 1 to 4%, and that's probably mostly driven by BRCA1 carriers as opposed to BRCA2. That being said, there isn't really great evidence for a post-risk-reducing surgery surveillance or screening. If there wasn't great data for doing ultrasounds and CA-125s before this surgery, there's definitely not great data after. And so while there may be some providers that continue to do some kind of assessment like CA-125 afterwards, that has not been my practice, nor do I believe it's the practice of my partners either. Other risk-reducing salpingo oophorectomy considerations is hysterectomy, and this is somewhat controversial. The overall risk of uterine cancer in BRCA1 and 2 germline mutation carriers there is no increased risk of generally of uterine cancer, but there are some studies that have pointed to perhaps an increased risk of specifically serous or serous-like endometrial cancers, specifically for BRCA1 mutation carriers, and not so much for BRCA2. And so for BRCA1 patients, I do counsel about the potential for having an increased risk of that type of endometrial cancer, serous or serous-like endometrial cancer, and I do counsel that those endometrial cancers, unlike the most common type of endometrial cancers we see, which generally are low grade and tend to be less aggressive, serous or serous-like endometrial carcinomas tend to be far more aggressive with worse prognoses. And so for those patients, I do counsel about the possibility of doing a hysterectomy at the time of risk-reducing surgery. Doing a hysterectomy at the time of risk-reducing surgery, if you were going to use a hormone replacement therapy, and I really advocate that you should, it does simplify the giving that hormones back, because without a uterus in place, you could really forego needing to give any kind of progesterone and just give estrogen back to these patients. Hysterectomy obviously adds increased surgical risk, OR time, and then recovery time from surgery. So for patients, while we can still do this outpatient and laparoscopically, a hysterectomy just adds a complexity onto what is otherwise could be a very, very straightforward surgery. Finally, well, not finally, but one other thing to consider here is beyond the BRCA1 and 2 mutations, those patients who have other germline mutations that confer an increased risk of ovarian cancer, of which there are many, the NCCN guidelines have pointed to a few that we should consider still doing a risk-reducing surgery, albeit later in life. So specifically for BRIP1, RAD51C, and RAD51D, the guidelines have been updated to now include this group in those patients who we should consider doing a risk-reducing salpingo oophorectomy. Finally here, so one other consideration would be hormonal therapy for these patients. And so for those women who undergo a risk-reducing salpingo oophorectomy, especially those who are unaffected and may have found out their BRCA mutation status at an early age, younger than age 40 or earlier, the risk of surgical menopause does confer a more abrupt, rapid, and then severe menopausal state. And that could be, the vasomotor symptoms, the genitourinary symptoms, and then longer-term consequences such as premature bone loss or increased cardiovascular risk, and especially the vasomotor symptoms can be extremely profound for these patients who are very young undergoing this procedure. And so the fear or the worry, I think, is always starting hormone therapy in patients who have a known syndrome that does have an elevated risk of developing a breast cancer. To address this, the Society for Gynecologic Oncology, so SGO, and then the North American Menopause Society have put out a clinical practice statement kind of guiding and summarizing the data for using hormone therapy in this high-risk population. And they do endorse using hormone therapy as acceptable for these patients who don't personally have a history of breast cancer at the time, which is an important risk caveat. You still have to do some risk stratification in these patients. If they obviously have a hormone positive breast cancer, you're not going to give them estrogen or progesterone back. But they do cite prospective longitudinal data using hormone therapy that points to BRCA patients not being associated with an increased incidence of breast cancer while using hormone therapy after surgical menopause compared to never users. And that data is long follow-up. It was nearly 8 years of being on hormone therapy, which, if you think about the average age of doing a risk-reducing surgery, which will be around 40, depending on your mutation, that'll get to nearly the natural age of menopause for the majority of patients that you'll see. Again, hormone therapy is going to be a bit dependent on whether or not you do a hysterectomy, and so obviously, if the uterus is still in place, you have to give some progesterone back. That could either be through an IUD and the patients won't have any systemic exposure to progesterone, or through micronized progesterone. And then the estrogen can be given in any form, patch, pill, ring, etc. And then for those patients who do have a known breast cancer, let's say, and you do want to avoid giving hormones back, there is still the option of being able to give non-hormonal treatments, especially for the vasomotor symptoms, such as Effexor, venlafaxine, but also fluoxetine or Paxil as well. And then obviously, depending on what the menopausal symptoms may be, there may also be some leeway in terms of being able to give other adjuvants, clonidine and so forth, or for just genitourinary symptoms that are severe, considering vaginal estrogen within that population. But this I find is probably the bigger point of discussion with patients when we're talking about a risk-reducing surgery. It's a complex decision. The counseling can be challenging at times. It can be helpful to have that counseling visit over more than one visit, and really integrating the patient's kind of goals, their family planning, and their family history into that discussion is extremely important. I'm going to stop. There's we probably have about 10 minutes or 15 minutes or so, 12 minutes left at the end of this, where we can talk a little bit more. I could just go through some of my rejected cartoons instead, if you guys want to do that. But otherwise, are there any questions that we can answer, or a discussion that has been brewing in the chat that I've missed? I'm happy to engage. Thank you for your time. Okay, so here we have a question in the chat. Can you comment on regarding the risk of dementia when a RRSO at a younger age inducing premature menopause at 35 years old? Is there evidence giving estrogen therapy prevents the dementia risk? No, so we don't have great evidence that it prevents that. That some of the neurologic risks that we worry about with early surgical menopause, we don't have great data that's about modifying that risk in that long term. I think part of it suffers from the kind of small cohort, but to my knowledge, we don't have great data to that it's going to mitigate that risk. Although I will say that that data for the data describing that risk is also challenging. So it's hard to say kind of what if estrogen is going to be the sole culprit in that situation. So I don't know if we have the ability to really to strongly and confidently tell patients that if we start an HRT that risk of dementia is going to go away or be significantly mitigated. Other questions? And I don't know if the people can talk too. I'm happy to not answer questions on the chat and have people talk.
Unfortunately, with the webinar, only the chat box works.
Got it. All right. Well, if there are any other questions, we could throw them in the chat. Or if there's anything I didn't touch on, this is a pretty focused talk considering the potential scope of the subject. So if there's anything else about BRCA that people are interested in, I'm happy to also discuss that as well.